Welcome back to another episode of Dance Med Spotlight. In this episode, I have a chance to speak with Dr. Mandy Blackmon. She's a physical therapist, the head PT for the Atlanta Ballet, co-owner of Atlanta Dance Medicine, and a senior instructor for Myopain Seminars, teaching dry needling to healthcare professionals. In today's conversation, we talk about not only some of our favorite topics when we're talking about dance medicine and the health and wellness of our dancers, but we more specifically dive into things like hypermobility and how we identify that, how we help support those dancers who have a hypermobility diagnosis. We also talk about the use and application of dry needling with our patients, whether they're hypermobile or not. Those are just a couple of the topics that we talk about in this episode, so be sure to check this one out. Welcome back to another episode of Dance Med Spotlight, where we talk about all things dance medicine and dance science. Today, I am excited to be chatting with a fellow physical therapist in the dance medicine space, Dr. Mandy Blackmon. Welcome.
Thank you.
So, Mandy, one of the things that I always start off these conversations with is give sort of the short story version of how you ended up at this place of working very specifically in the dance community and in the ways that you work within that community.
Yeah, absolutely. So I grew up dancing, but as a very recreational dancer, and actually decided when I was in middle school that I wanted to go to PT school, but actually was headed down a more neuro pathway. My granddad had a stroke, and that's what really introduced me to PT. I, knock on wood, made it through my dance career without any significant injuries. So I hadn't really been exposed to orthopedic PT, and then worked in an orthopedic PT practice all the way through, well, the end of high school, all the way through college. And even when I went to PT school, I still thought that I was going to be doing more of a neuro track. Got to PT school, absolutely hated neuro, couldn't have hated it more. And I really missed the dance and performing arts world. So I completely changed my focus and got my Pilates certification and started looking for dance medicine mentors right after PT school, and really kind of focused from there
Mm-hmm.
on
That's
dance.
awesome. And it's funny, there's a lot of detail that I resonate with. I also had a grand plan of neuro PT because
Mhm.
my mom had a accident with a traumatic brain injury as a result. And then I got into it and it was like, nope, this isn't the right. So yeah, I understand entirely. So some of the things that you're involved in, head PT at the Atlanta Ballet, co-owner of Atlanta Dance Medicine, and then also a senior instructor with Myopain Seminars,
Mhm.
teaching dry needling, a really nice kind of eclectic mix of things, giving you some different experiences and different groups that you get to work with.
Mhm.
Let's maybe start with, actually, let's talk about Atlanta Dance Medicine a little bit. For people who aren't familiar with your organization, share a little bit with the group.
Yeah, I'm happy to. So my business partner and I, Emma Faulkner, worked together previously. She was actually my student. She was my student when we got the Atlanta Ballet contract.
Mhm.
And at that time, we were working for a different organization. And we both left that organization in 2018. Both kind of went out on our own, but I was still treating Atlanta Ballet, and she was still helping me treat Atlanta Ballet. And we started Atlanta Dance Medicine at that time as more of an educational umbrella. We weren't truly intending on starting a brick and mortar PT practice. We wanted to present at conferences and host dance medicine classes and that kind of thing. But we really didn't have our eyes on brick and mortar. And then July of 2020, so right in the dead of COVID, um,
Mhm.
a dance studio owner here in Atlanta called us. She'd been in business my entire life, so over 40 years. And she was building a new studio, 25,000 square foot dance studio, and said, I really want you guys to come open a clinic inside my dance studio.
Mhm.
We're like, oh, we both have all these other jobs. We're not sure we can do this, but okay, yeah, let's do this. So we opened our first brick and mortar clinic in September of 2020.
Mhm.
And we have grown to, I believe now we have 15 therapists, 3 locations, but everybody's working on a very part-time basis. Most of our therapists also have other full-time jobs or wear other hats, or they're just working part-time for us because they're also young moms with little bitty kids. So
Mhm.
everybody kind of piecemeals it together, but it's that group that now covers Atlanta Ballet. And then we mostly treat adolescent dancers out of our other 3 clinics, but also treat normal people as well, a lot of dance moms and hypermobiles. And we have one therapist who specializes in gymnastics and aerialists. So we do a little bit of everything.
That's awesome. And I think once you start getting into this space of working with dancers a lot, it does become a lot of the family members of the dancer come in, or, when I have been talking with somebody about hypermobility stuff and, I have some suspicions here, let's check this out, let's send you somewhere. And as we're having the conversations, mom who's sitting there or dad will go, huh, some of this sounds really familiar to me too.
Yeah.
And they're
Sleep
they're
light
doing
bulbs
some
go
different
off.
things. Yeah. And it's like, huh, maybe, maybe this applies to me too. So yeah, it's interesting because it's all in the family. But it definitely lets us kind of expand beyond just our dancers that we think of, which
Yeah,
is
and
cool.
it's definitely made for a cohesive dance medicine group in the Atlanta area, because if people can't see us in our practice out of network, we refer to all of our therapists who work for us throughout the city. And it's also given us a great network for any kind of show coverage. So You Think You Can Dance was just in town, premiered Monday night. They've been filming here in Atlanta
Mhm.
for 6 weeks now. We've been covering them. We cover all the other like small companies around town. So we can really piecemeal our therapists together and allow so many more people dance medicine opportunities versus just Emma and myself trying to treat every dancer in the metro area, which would be
Mhm.
crazy. So it's been good.
Yeah. And it's nice to be able to kind of embrace all of the options for the therapist that you work with of, how do they still fit it into their lives? And is it something that they do, in addition to something else? Or is it just where they are in life? That's the amount of time that they want to dedicate or whatever. And it's not just, nope, this is a full time, this is the only way it looks. And I think it fits really nicely in the dance community because dance also looks many different ways and has a lot of different needs too.
Exactly. Yeah, it's been great.
Um, as you've been working in this space for a while, whether it's specifically in Atlanta dance medicine or with Atlanta Ballet,
Mhm.
what are what do I want to ask? What are some of the major trends that you've maybe seen over time as far as, let's start with just the idea of like accessing dance medicine and awareness of dance specialists?
Great question. So when we first got to Atlanta Ballet is an AGMA company, so they're under the auspices of the union, and
Mhm.
they renegotiate typically every 3 years, sometimes every 2. And when we got there, they only had 8 hours of therapy services for, I believe back then we were 36 dancers and they had 8 hours a week.
Wow.
Now we're up to 15 hours. That also includes AB2. So it's 15 hours for closer to 50 dancers.
Mhm.
Probably still not enough, but it is more. And it's been nice too, as we've gotten more involved in the dance community and gotten dancers from other companies across the country, say, Houston, Boston, San Francisco. It's nice to get those phone calls from my colleagues who are therapists who have already treated these dancers, and we get a little bit of the heads up, or that dancer's already been told, oh, you have a great team in Atlanta, like go use them. So it manages their expectations a little bit. And I
Mhm.
think it can decrease their anxiety a bit if they know they're already going to have people who see them, understand dance medicine, and are networked with their dance medicine people that they've already had exposure to. So I hope
Mhm.
it's becoming more the norm in at least the professional community. Um,
Yeah.
based on our Dance USA task force meetings, it seems to be more the norm, but that's still mostly very, very large, typical ballet companies, where I know some of our smaller, more contract companies, more pickup companies may not have that kind of access or the funds available to them. So that's where we try to be like a networking group and at least let ourselves be known. We offer freelancer screening days to at least get the word out that dance medicine is a thing. Hopefully
Mm-hmm.
becoming more recognized.
Mm-hmm. I feel like even just in the last few years, it's shifted quite a bit as far as that recognition and things where, like this past weekend, I was on site at Denver Ballet Guild's Young Dancers competition.
Mhm.
And it was the first time
I
they
saw
had,
your post.
what's that?
I saw your social media post. I think
Oh,
Bridge
yes.
Dance Project posted about it. Yeah. I was like, oh,
Yes.
there's Alyssa.
Yes. Yes, I always love sharing all the things on there. And it was the first time that they had a group like us in that space at that event. And there was a talk that was given by Dr. Stephen Karaginas, who was fantastic. And
Mhm.
then that kind of drove people out to us. But there were so many people that were coming up to us, the parents mostly, who were
Mhm.
like, oh my gosh, I love that you're here. This is amazing. I didn't know that this sort of thing existed. And just the enthusiasm that they had having
Mhm.
seen us there. And so now it's like, okay, how do we keep this momentum going? How do we continue to replicate this at other things,
Yeah.
to just help the word get out and the excitement get out about it too?
Because just that little bit of specificity can make all the difference in the world to a dancer. If you ask them to do a plie instead of asking them to do a squat, you've already gotten buy-in, as you know. Social media has been a good asset, I think, especially during COVID, right? Because people were just
Mm-hmm.
on the socials more and putting more um, videos out and imaging out and more infographics out about dance medicine. So I think it has gotten much better.
Mm-hmm. Yeah. What Let's kind of shift gears a little bit. We already kind of made mention briefly of some of the folks that we may see in the clinic that we're working with, whether they are dancers or sort of dance adjacent in some form.
Mhm.
Really thinking about our hypermobile folks, and hypermobile dancers for the sake of this podcast.
Yep.
Um, I know with your background with the dry needling and being an instructor within that area, what are
Mhm.
some things that you've seen working with people with hypermobility, and specifically how you maybe apply concepts with dry needling in relation to that?
Absolutely. As we know, hypermobiles tend to be people who have hypermobility tend to be extra sensitive, right? And they tend to have a lot of chronic pain. And there are a lot of reasons for that: wind up of the nervous system, central sensitization, chronic pain, chronic pain, chronic pain. Um, but the way I explain it in layman's terms to my patients with hypermobility is that their muscles are working on overtime, trying very hard to hold their joints together and to give them some kind of stability. And the way trigger points and pain develops is because those muscles are going into an energy crisis and working on overtime.
Mm,
So the hypermobile patients tend to love the dry needling because it's like scratching an itch they can't get to, right? We
yeah.
needle that hypermobile shoulder and it feels amazing to them, but the risk is that we then take away the external stability that they are using. So
Mhm.
I warn a lot of my students in the dry needling classes, a lot of them don't think that they're seeing hypermobile patients daily, and they are. But B, it is very, very easy to over needle these hypermobiles, take away that stability, and you have to follow up with not only appropriate neuromuscular re-ed and exercises, appropriate being the operative word.
Mhm.
But also, I use a lot of external stabilization, like kinesiology taping, compression. Like, I wish I would have bought stock and Spanx years ago before they became a thing, because I've been
Mhm.
prescribing them for my hypermobiles for years and years and years. But there's so many new compression garments and compression wear out on the market that I think can be really helpful but a lot of them just really love to be taped. And we can put them back in place and give them some of that external proprioception while they're doing their software upgrade to develop what they need internally. So
Mm-hmm.
my biggest thing is not over needling the hypermobiles and not getting them too addicted to it.
Yeah, that balance is really important. I actually have a client who she has kind of bounced back and forth between Denver and another state. And when she was in another state for a break time, she decided to work with somebody out there, which fine, cool. She needs additional help, so that's totally fine. But she worked with somebody who I'm not sure how familiar they were with working with folks with hypermobility.
Mhm.
And because of headaches and jaw pain and different things, they were needling kind of up in that suboccipital area at the base of the head. And she said it felt really good. But then I started noticing like I had more pins and needles in my arms and, weird things with her jaw and all of these different things. And so as we're digging into it more, it's like, I think that was a good example of
Yeah.
maybe a little too much needling and not enough reinforcement afterwards
Mhm.
to still create a balance for her. And so
Mhm.
now we're kind of delving into, we're going to start doing some dry needling in this, but have a very specific approach in what we're doing with it.
Right. Following up with that neuromuscular rehab.
Mm-hmm.
So
Exactly. Because you mentioned this with the hypermobile folks, I have definitely noticed as I've gotten more into the dance medicine world and just continue learning things all the time and that
Mhm.
sort of thing. To your point, a lot of times we are seeing folks that we don't necessarily recognize as being hypermobile if we aren't familiar with that
Mhm.
area. So,
Mhm.
for folks who aren't familiar, what are some things that you see that maybe are little flags of, maybe this is some form of hypermobility that I need to be aware of?
Oh, that's such a good question. Thank you so much for asking. So everybody calls hypermobility, especially Ehlers-Danlos, this rare disease. And I don't think it's that rare. I think we're actually seeing it a lot. And I have an intuition or just a clinical hypothesis, maybe, that COVID is unmasking these hypermobile symptoms in a lot of patients that
Mm,
maybe have been flying under the radar and they weren't quite symptomatic. And now they are
yep.
after having had COVID. Um, so one of the outcome tools that I recommend for new therapists to use is the central sensitization inventory. Are you familiar
Mm.
with it?
I've heard of it, but I haven't used it yet.
It's a great form. I want to say it's like 20, 25 questions maybe, but it asks a lot of the sensitivity questions that I tend to ask in my initial subjective interview that are kind of like my little flags. So
Mhm.
things like non-restorative sleep, anxiety, history of ADD, restless legs is on there, history of pins and needles and nerve type symptoms, history of chronic headaches and migraines. And then there's all the sensitive stuff. So light sensitivity, noise sensitivity, smell sensitivity, food sensitivities and allergies,
Mhm.
history of GI type stuff, either the IBS type, swinging back and forth between chronic constipation or diarrhea, along with those food sensitivities. There's a pelvic pain question on there that applies to males and females, the way it's worded.
Mhm.
But for my women, I often go a little bit deeper into endometriosis, painful periods, fibroids, cysts, pain with intercourse, those type of questions, obviously, if it's
Mhm.
age appropriate. Um, trying to think what else are in my kind of red flags. The noise, light, and smells, along with like chemical sensitivities to like pesticides and perfumes and things like that, is
Mhm.
one that always sort of turns on a light bulb in my patients if they are centrally sensitized, which a lot of times those patients are hypermobile. I had one patient tell me, no, no, no. And then she's on my table. We're going through our objective exam. And she goes, I do turn off the overhead lights in every room I walk into. I do always have earplugs with me.
Hmm.
And she goes, and it really drives me crazy when my boyfriend wears any kind of cologne or anything that smells. And I'm like,
Yep.
but you didn't even think to say yes to those questions when I asked you subjectively, because it's become so much of her everyday life. She doesn't
Mhm.
realize how sensitive she is. And I'll make jokes like, were you the kid that turned your socks inside out because you couldn't stand the seams? Were you the kid that cut all the tags out of your shirt? Were you the kid that like couldn't sit still in class and you're fidgeting and nobody wants to watch a movie sitting next to you because you literally can't be still? So I think a lot of times when you start making light of it and just throwing some little anecdote things in there, people do tend to recognize themselves in that presentation. And they're like, "Oh,
Mhm.
yeah, that is me." Or do you
Mhm.
find bruises all over yourself and you don't remember running into walls or your coffee table or, the corner of your bed that's been in the same place for the last 10 years, yet you run into it all the time because their proprioception is so off, right? They don't
Mhm.
know that all of this stuff goes together. So
Mhm.
I think recognizing them early on through some of that stuff, but also then validating that all of those things are coming from kind of the same connective tissue pathology or disorder can be very
Mhm.
validating for a patient that they're not just crazy and sick.
Yeah. I think it was so helpful when I started learning some of those details of what to ask about and some of these presentations that can come together. And also, um, kind of down the line where it's vision changes sometimes can be part of it, or like you
Lots of
said,
moving.
allergies and GI, yeah. And what was another one? Oh, and more likely for any sort of like neurodivergence type stuff.
Absolutely.
There's so many things that like we are starting to hear about more now as we are talking about neurodivergence as a thing or
Mhm.
whatever. And it's like, no, but all of these do have some intersections too that we need to appreciate. And I remember when I was in PT school, I think we had like 2 slides saying that hypermobility is a thing, and that was sort of it.
Mhm.
And there's so much more that we need to understand so that we can help identify these patients and help them start to get connected with the folks to help them manage themselves as a whole and not feel like they have 20 different diagnoses going on. Or, I'm just weird and my body's breaking down and my body hates me because I'm experiencing all of these things. It's no, there is one central thing that's contributing to a lot of this that we can help manage.
Well, and it can be such a shock, especially if it is a dancer that we're talking to. Because I don't know if you've seen this, but I find that they actually do pretty well, many of them, until they quit dancing or until their dancing dramatically reduces. So,
Mhm.
say they were a recreational dancer dancing 20 hours a week, and then they go to college and now they're doing an hour a week in aerobics. They start to have chronic pain, they start to fall apart. And I think it's because all the exercise they were doing was protective, right?
Mhm.
And then when they quit doing as much, all of those hypermobile symptoms kind of kick in.
Mhm.
Or there's some kind of trauma, like a motor vehicle accident or an ankle sprain or a divorce, God forbid, that almost like unmasks everything and their entire nervous system gets out of whack.
Mhm. Yeah. I think the other thing too that people don't necessarily recognize is when we think hypermobile, we may picture this like super bendy, almost that like contortionist type
Mhm.
thing. But people can also have hypermobility that is just in a single joint or a couple of joints, or, somebody who does have some of these different characteristics, but they don't look like what we would stereotypically think of as a hypermobile person.
Exactly. Especially when it's a male. I mean, the males are really shocked. They're like, "I'm not hypermobile. I can't even touch my toes." Oh, but you've
Mhm.
all this other stuff going on, and all of your finger and hand joints are hypermobile, and you're still an 8 out of 9 on the Biden.
Mhm.
They're shocked.
Mhm.
Seeing it more and more in men and boys.
Mm.
It's pretty
Yeah,
crazy.
yeah. When you are starting to identify this with somebody that you're working with, what is your typical sort of next steps outside of what you're doing in the clinic as a physical therapist, but as far as like, who are you referring to them? What sorts of testing or diagnostic stuff are you maybe talking about from a
Yeah,
management
great
standpoint?
question. So are you familiar with the book Disjointed?
Mm-hmm.
It
It's a good
came
one.
out, I think, May of 2020, like right when we were in COVID, when I had time to be sitting at home and actually reading. And
Perfect.
I know a couple of the authors on that book, including Dr. Linda Bluestein, and I knew her before that book came out, and it has really become my hypermobility Bible.
Mm-hmm.
So a lot of times, if I have a patient reach out to me and maybe I'm not going to see them for 2 or 3 weeks, and I know they already have a hypermobility diagnosis, I will, in my initial email to them, say, I want you to go ahead and get this book, and I want you to read chapters XYZ. Do not
Mm-hmm.
try to read the whole book at one sitting, right? Because it's a lot to digest.
Yeah.
But read these initial couple chapters, or read the chapter on pain management, read the chapter on pharmacology, just so you can start getting an idea of what we're getting into. And I think just a few of those intro chapters can also be very validating, right? Because
Mm-hmm.
it's like, oh, there are other people like me.
Yeah.
So that's my number one starting, is getting them that resource, referring them toward Dr. Bluestein's podcast that she has
Mm-hmm.
called Bendy Bodies. I think that's a great resource. And then kind of figuring out from a medical professional standpoint, what specialist does this person need to see? Are they showing symptoms of any kind of, God forbid, vascular or POTS? Do we need to be referring to cardiology? Or is it presenting more of a GI perspective, and we need to get them to a gastroenterologist who understands hypermobility and food sensitivities, and that these things are real? And
Mm-hmm.
so that's kind of like teasing out, because you don't want to throw them 20 specialists,
Yeah.
right? You have to kind of prioritize, and then getting them in the idea that they may be a long-term PT patient, but that may look very different. It might be once a week in the beginning while we're dealing with whatever this initial thing is. Um,
Mm-hmm.
but as they move on, I want them to be a once a month, and then a once every 6 weeks, and then a once every 2 months, where they feel like they can come in for what all my hypermobiles call their tune-up, right?
Mm-hmm.
Kind of put out the fires that are showing up, handle whatever urgent thing there is right then, maybe update their exercise program, check in about what specialists they're seeing and who they're dealing with, and kind of get them on that, manage their expectations that this is going to be a long-term thing, not a 6-week bout of PT.
Yeah. Thinking about folks like dance teachers, studio owners, artistic directors who maybe have dancers that they're now hearing like, oh, they're hypermobile, or maybe they're recognizing some of these things of, I'm thinking maybe there's something hypermobility that would be worth checking out. What are some things that you would love for them to understand about working with their dancers who are hypermobile?
Not glorifying their hypermobility, right? Like, it's great that they can do the party tricks, but the party tricks are hurting them. So can we try to avoid putting that needle into that particular dancer's choreography, because it is in fact destroying their hip joint? That would be one. Learning just the basic physiology and science about stretching, that these dancers
Mhm.
do not need to be holding their overstretch for 10, 15, 20 minutes at a time.
Yep.
That would be huge.
Mhm.
And then I think allowing dancers, or making dancers feel very comfortable if they need to come into the studio taped, if they need to come in the studio and take care of their body and modify accordingly.
Mhm.
Hey, my body's telling me I'm not jumping today. Great. Good for you for having self-efficacy and taking care of yourself. If we could help these young dancers not be afraid of artistic and teachers, it would be
Mhm.
really lovely.
Yes. I think that that is such an important conversation, and something where I think, kind of the culture of dance and the arts for a really long time has been either we just suffer for our art, pain is normal, or it's good that, it hurts because that means you're accomplishing
You're working.
something, or also the idea of it is normal and expected to work injured.
Mhm.
I know I had dancers that I worked with before, or even people that I've just like known in life that weren't clients of mine, that have said things like, I had 3 stress fractures in my foot and I came in a boot and had already seen the doc and started PT. And the artistic director had said, well, can you just suck it up and do your solos on point that are in this show? We just have a couple of weeks left. And that sort of thing. And it's like, that has been the culture.
Yeah.
And so how do we help that shift so that the dancers can have an opportunity to advocate for themselves, make sure that they're prioritizing their own health and safety? Um, it's an interesting kind of place that I think we're starting to see some transition in, but definitely have a lot of room to grow too.
Yeah, absolutely. I was talking to one of my professional dancers yesterday, and I didn't know this. He's new to us this year, but he already has his master's degree in it's a master's in the arts from Poland, but with a specific focus on um, kinesiology and dance pedagogy. And
Mm,
apparently, you are not allowed to teach dance in Poland unless you have a certain amount of training in development, biomechanics, kinesiology, pedagogy.
mm,
Isn't that novel and amazing? And why are we not doing that in the United States? Why
mhm,
are we putting our children in the hands of often untrained professionals who are teaching dance because they got injured, not because they have training in child and adolescent development and how to actually teach dance?
mhm.
It just doesn't make any sense. And it's not just the
Yeah,
dance world, as we know, it's all of these adolescent sports in the United States.
yeah,
But as a parent and as a healthcare professional, I'm like, how is this still happening in 2024? It should be a
mhm,
requirement for
mhm.
dance teachers if we're going to put our children's health and well-being in their hands for them to have some kind of training in these things.
Yeah. And a lot of times, especially when we're looking at, kind of more local dance studio level, sometimes what'll happen is dancer grows up at the studio, they sort of graduate out of the typical program and they're invited to be a teacher with them. And that's kind of where most of their teachers are. And so they teach in the ways that they were taught. They continue the same traditions that they were taught. And
Yep.
then because there aren't any requirements, a lot of times they're not necessarily looking for some sort of continuing education or additional trainings or certifications or whatever that might look like. And so we're not seeing some of those changes being implemented that are out there versus some of the studios, or even I see it like in the school systems where they have someone teaching dance there because they are a licensed instructor. They do have requirements for continuing education. They're the ones that I see more often at some of the conferences and courses and things like that because they need to be there.
Yeah.
But they're
And
also
exactly.
really great advocates
Yeah.
of doing it because they've been learning it.
Yeah. It's fantastic. But I was that person. I taught 20 hours a week my senior year of high school.
Yeah. Yeah.
It's
Exactly.
terrifying.
Exactly. Yeah, I think, I've heard of at least 1 or 2 organizations that are talking about, like, is there a way that we can create some sort of, like, dance teacher licensure or, something to have some sort of
Certification.
regulation in there?
Yeah,
But I don't know that that is quite accomplished yet, but at least the conversations are happening. That's a start.
for sure. And they're happening at places like iAdams and PAMA and all of these Bridge Dance Project, like all of these wonderful organizations that are in place for people like us and dance teachers who are interested in keeping kids safe to join, which is great.
Mhm. Exactly. Since you've had an opportunity to work with a wide variety of types of dancers, levels of training, whether they're adolescents and kids versus professionals who've been in the area for a while, what are some uh, things that you're seeing? Let's see, how do I want to phrase this? Let me backtrack for a second.
Mhm.
So, this last weekend at this Denver Ballet Guild event with Dr. Karaginas' talk, there was some discussion of like how we have advocacy for the dancer, keeping them healthy, keeping them safe. And then parents were coming up and talking to us afterwards. And one of the things that got brought up that I thought was a very interesting point is a kid who had said, I understand what he was talking about. I think it's, great ideas, things that would be cool to implement, but I also haven't seen people who have followed these guidelines and have a successful dance career. Hearing that and
Mhm.
working with the folks that you have worked with,
Mhm.
what is your thought, your response?
So I'm guessing the guidelines you're talking about are like our typical adolescent athlete guidelines of no more hours of your sport per week than your age. Like that's a good rule of thumb that I will tell a lot of parents. And the
Yep.
parents look at me like, you're crazy if you think my 12-year-old who's trying to be an elite pre-professional ballet dancer is only going to dance 12 hours a week. Like she'd be kicked out of the studio.
Hmm.
And I say, I hear you, but you need to understand those are the health and safety guidelines. Just like if your child were a baseball pitcher, we have a pitch count that they're finally starting to stick to because the science is showing that if we get past that pitch count, performance is going to go down and injury is going to go up. Right. So we have these guidelines. And I think if it would become more the norm, we would actually see higher levels of performance. But
Hmm.
how do we break into the tradition of you have to be in the studio for 30 hours a week to even be competitive?
Yeah.
I don't know. I don't
Hmm.
know. So
Hmm.
for me, it is getting parents to advocate for their child in a okay, the 12-year-old is going to dance 15, 16 hours a week. But let's not also have that 12-year-old do running and jumping and PE at school, right? Let
Hmm.
them do some other kind of cross training, some other kind of physical activity that isn't so similar to dance and so hard on their bodies, right? Let them
Yeah.
swim for an hour or two a week. Let them do something outside their sport or activity to kind of balance out the repetitive nature of dance. And then also the parents giving the kid permission that if they are injured or not feeling well, or they have a final exam or whatever, that they can pull back a little bit that week, right?
Hmm.
Yeah, we paid for the money. We paid the money for the classes. Yeah, your instructor is telling you have to be there, but I'm giving you permission to give yourself permission to listen to your body. And on certain weeks, maybe you do 15 hours instead of 20 hours,
Hmm.
right? Just come a little closer to the guidelines.
Yeah.
Because I think you're right. I think a 12-year-old dancing 12 hours a week probably isn't going to go pre-pro. They're not in the studio enough to be under the eyes of the artistic director to be selected for the parts to launch them up. But how do we
Hmm.
change that over time?
Hmm. And I think it's something where it's probably going to end up being more of kind of that long game of people start learning it, people start, it kind of gets ingrained. And then maybe the next generation, when they are the dance teacher at the studio now, they go, I've been learning this. I experienced some of it myself. Let's see if we can incorporate some of this.
Yeah.
Um, it might not be now, but eventually.
And my business partner would throw in here a little caveat for let's replace some of those hours in the studio with other things like
Hmm.
choreography specific conditioning,
Yeah.
right? Like, why, if we're doing 6 contemporary pieces, does the ballet class still look just like the ballet class, right? Can we do a class that looks more like the contemporary stuff that we're trying to work on in the choreography,
Hmm.
right? So make an hour of that 15-hour week strength and conditioning that's choreography specific. So they're still in the studio, they're still working, but in a
Yeah.
little safer way that's promoting health and wellness, not diminishing it.
Hmm. One of the studios that I work with, I really like some of the things that they've started to implement where, for some of it's mostly for their older girls now, their older dancers. They have like a choreographic class where they get to learn how to choreograph, and they still dance and they still move and all of that kind of stuff. But like that is part of their time in the studio.
Mhm.
Or they periodically invite people in, and I've come in for this, where it's like, come in and talk about how you work within the dance space, even if it's not traditionally as a professional dancer somewhere. And
Mhm.
so, whether it's me coming in as a PT that works with dancers, or, maybe they have a costume designer come in, or who knows what, but, they have some things like that. And that is part of their time in the studio. I love that idea. And there's so many different opportunities of how they can still make it meaningful, still make it dance specific,
Mhm.
but it doesn't mean that they are in there doing another technique class.
Yep, and just bashing their bodies. More of a
Mhm.
holistic dance curriculum rather than just dance class.
Exactly.
I love that.
Yeah.
Can we
I know
spread
every
that
time.
around the world?
Yes. Yes, exactly. Exactly. And they have a nice diversity of some of the things that they do. They are kind of a traditional competitive studio, but then they have like there's another competitive group that is ballet specific, or like they just brought in ballroom as another option for the kids to take, just to have some diversity in what they're training in. Or like I've come in and I taught a West Coast swing workshop for them, just
Love
to
it.
get exposure to that. And so yeah, I mean it's cool what they've been doing there, and seeing how they've kind of morphed what maybe has been the traditional for a studio like that.
That's awesome. Very
Mhm.
cool.
Um, let's talk a little bit more about the dry needling side of things. We'll go back to that. For people who are not familiar with what dry needling is, can you give a little spiel for them?
A little elevator pitch on dry needling?
Yes.
Yes, I'd be happy to. So, we're taking a solid filament needle, palpating for an active trigger point, meaning a trigger point that is tender to palpation, palpable by the practitioner, and may or may not refer pain. Okay. Um, we're taking that solid filament needle, sticking it into the trigger point. Typically, that's going to cause a localized twitch response where it makes the muscle contract and then relax. And then we might be needling other spots, other muscles, et cetera, et cetera. But when that localized twitch response happens, there's a biomechanical change that happens at the tissue level and at the connective tissue level. But there's also a biochemical change that happens. So if you think of that little trigger point as a little knot holding on to all the pain chemicals, when I go in with a needle and needle that knot and the knot releases, it's releasing those pain chemicals into the surrounding tissue. So I kind of compare trigger points in the muscle to when your computer goes into the spinning wheel of death, right? It
Yes.
won't move forward, it won't move backwards, it's just stuck. And when a muscle has a trigger point in it, it can affect that muscle's ability to lengthen. It can affect its ability to relax, contract. It can affect its endurance and fatigability. It can affect its power generation. And also, it can be painful as well as causing other autonomic symptoms that can be really weird. Things like,
Mhm.
this, Alyssa, things like pressure in the ear or sinus drainage. So when we go in with a needle, it's almost like hitting Control Alt Delete on the computer and resetting that muscle. But we then have to do that software upgrade of our neuromuscular re-ed or our stretching program or our strengthening program, to make sure that that trigger point doesn't come back.
Mhm.
And we also have to play a little bit of private investigator looking at why that trigger point developed in the first place. So was it because of a sustained or repetitive posture, something like a pec or a pec minor from our teenagers sitting on their computers or on their video games? Or in the
Mhm.
case of a dancer, is it a trigger point that developed in the FHL because of poor jumping mechanics, right? We have to be the private investigator to figure that out, to then also give that dancer a program to try to keep that trigger point from coming right back.
Mhm. I love that analogy with all of the computer stuff. I might have to borrow that
You
because
can
that's a good
borrow
one.
you can borrow it.
And I think one piece of it too that we as the clinician doing dry needling need to be aware of, whether it's dancers or anybody else, is using it judiciously, not just like we were talking about with the hypermobile folks
Mhm.
of not overdoing it and making sure we're following up correctly, but also when are we utilizing it in relation to what they need to be able to do? Like if they're about to go on stage or they're about to compete, I'm going to look at that a lot differently than somebody who has a couple of days off and, they don't have any like big moving and big physical demands for the next day or so. Making sure that we're making the correct choices clinically when we're deciding to apply that technique.
Absolutely. And, for a lot of practitioners across the country, this is a very new and novel technique.
Hmm.
And I get on a soapbox when I find out practitioners have thrown all their other tools out of their toolbox and they're just doing what I call a la carte drive-through dry needling.
Hmm.
And patients are just coming in and getting dry needled, and it's not being used as a piece of a holistic plan of care, right? That should also include all of the other tools in our toolbox. Granted, it
Yeah.
is a very powerful tool,
Hmm.
but we have to do all the other things that we are already trained as far as being movement experts and prescribing appropriate therapeutic exercise and using our other manual therapy skills in conjunction with the dry needling.
Yeah.
I've seen some scary things out there, and if we are not careful as a profession, patients are gonna get hurt, and we're gonna get the right and the privilege of dry needling taken away from us.
Hmm. Yeah. I know my use of it in practice has also morphed a lot over time.
Mhm,
I did my certification 12 years ago now, so I've been doing it for a while.
mhm.
And early on, it was that shiny new tool that's really cool that does do a lot of good, but it was like I'll needle everybody, and that sort of thing. I went a little crazy at first with it, and then started realizing, okay, I don't need to needle everybody. I don't need to needle them every time. You know, I need to pare back on this. And so now I find that it definitely varies from patient to patient, but more of my approach now is let's try a couple of other things first. Let's see how the body responds where we don't need to be invasive, maybe. Um, See if it's willing to work with that. And if it's being stubborn, then I use it. Or I have somebody where it's like, I've done this before and I know it works for me. Cool. I'm going to use it a lot sooner for that individual.
Yeah.
But it's not just this like blanket, everybody gets it. It's not that like, the Oprah meme where it's like a car for you and a car for you. I don't do that anymore, thankfully.
Yeah.
But yeah, it's choosing when and how to use it for what person at what time.
Mhm.
Um, and it does really cool things when we do use it.
Really cool things. It's pretty miraculous.
Hmm. I think one of the wildest stories that I remember was early on after I had done the certification. I was working at a clinic that had 14 therapists, and I was one of, I think, two who had done the certification and taking the classes. And so a lot of times I was inheriting folks from other clinicians where they'd been working for a while, but they were kind of hitting a wall and they go, hey, you have this other skill set. Can you try some stuff? And there was a guy who was active military, had gotten hurt while deployed, had lots of different things going on with him, but main ones were he was having nearly constant, pretty intense headaches, lots of body aches and pains, and his balance was terrible. And something was so amiss with his nervous system that digestion was also off. And so, like, he couldn't really eat solid food. And they give him to me and they're like, here, do something. I'm like, I don't know what to do with all of this. Like, what? And so I started at a place that seemed like a reasonable place. I did a couple of needles up in the upper trapezius, up in the shoulders. And he came back in the next time. His balance was better. His headaches were better, almost gone. And he had been able to eat half a Chick-fil-A sandwich. And it's like, all I did was needle the upper traps. Like, why
Yeah.
was this a thing? And then unfortunately, things with his insurance, that's a whole nother story. That was like the end of his time with us. But like, that was incredible to see that, because, even though when I was taking the classes, we talked about what an impact it can have, I had never seen it to that level. And
Mhm.
especially from just, working on a single thing, getting to see that kind of change was really cool.
It's huge. Yeah, I think I talk about upper traps and thoracic multif as being the two main windows into the system, right? You can make massive changes just in those muscles, and you have to use your creative writing on why you might be needling thoracic multifidi for your kiddo presenting with the CRPS and their left foot. But
Mhm.
it is an appropriate clinical treatment and makes sense when you use your clinical reasoning. And upper traps makes complete sense for that all over widespread pain and symptoms.
Mhm.
It is really cool. It's a great tool.
Yeah, and bodies are cool.
And we have a cool profession, don't we?
Yeah, for sure. I basically, it's all an excuse to just nerd out about things all the
Mhm.
time.
Mhm.
That's what it boils down to for me. Well, at this point, I think this is a good opportunity for a special segment on the show. So we have the final bow. This is essentially your take home message for the audience. We've talked about several different topics. What is something that you hope the audience walks away with if there was only going to be one or two things?
Awesome. I'm assuming most of your audience are either dancers, dance teachers, or dance medicine practitioners,
Yep,
correct?
exactly.
My number one take home would be join iAdams, join iAdams, join iAdams. And then if you have some extra money, also join PAMA. And if you're a physical therapist, also make sure you join the Academy of Orthopedics and the Performing Arts Special Interest Group. I think we can do the most for our patients as healthcare practitioners if we surround ourselves with like-minded people who can teach us, who that we can teach and collaborate together. And I think it would be the same for dance teachers,
Mhm.
right? If like-minded dance teachers are surrounding themselves by or with other dance teachers who are interested in preserving the health and wellness of our dancers, which they can do through iAdams, right? Um,
Mhm.
I think it's just going to be better for the entire dance community as a whole. So it's that collaboration, networking, hive mind thinking of no one person can fix all the issues we have in the dance world, but all of us together can make a difference. And I know being a member of iAdams and surrounding myself with like-minded professionals has completely changed my career. I mean, it
Mhm.
absolutely has. So that would be my big take home.
I
And then
love
if you're a PT, go get trained in dry needling.
that. Yes. Yes, I agree 100% with both of those statements. So, yes, and I did not prompt her to say this. Yes, all the things. I agree. The last and certainly not least, the shameless plug. So you have an opportunity to plug anything that you have going on, an organization besides iAdams that you want to shout out. However you'd like to use this, now is your time.
Oh, that's awesome. We are collaborating with the Dance Medicine Education Initiative out of New York, Andrea Zucco, and Atlanta Dance Medicine is co-teaching a class with her in September. I want to say off the top of my head, the dates are September 20th and 21st. It is a taping for dancers class.
Ooh.
And we are really excited about this really cool educational collaboration with Andrea. She's amazing. If you haven't taken any of her classes, I highly endorse her. And then Atlanta Dance Medicine does at least one class a year. But this year we're collaborating on that to do very specific taping techniques for dancers. So I'll plug that. I'll plug Pamela one more time. We're all going to London in July. And then we're all going to be in Italy in October for IADM. So there's a lot of really exciting things coming up in the dance medicine world in 2024 that I'm super pumped to be a part of.
That's amazing. I'll make sure that when we're posting all of this, I also include some information to find out more about Atlanta Dance Medicine and all that you're involved in there, as well as some of your Instagram handles and all of that sort of thing. But Mandy, thank you so much for your time today. It was great getting to chat.
Great. Thanks, Alyssa. Take care. Thanks for having me.
Dance Med Spotlight is hosted and produced by Alyssa Arms. We discuss all things dance medicine. This has been another episode from Dance Med Spotlight. The Dance Med Spotlight is intended for educational purposes only. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can be present.